Thank you so much, Jyoti sir, for that very kind introduction. Always an honor to be here. And CGM and pregnancy is again a very, very specialized or a niche area, but more and more is coming up. So let's gain some insights into the latest research and evidence supporting CGM use in pregnancy. There may be tons of studies, but I have tons of small studies, and that's one of the biggest limitation we have in this area. But I have picked up some important ones to share with you. Thank you very much. The entire team of DMIDU, very, very honored to be here. And again, I think let me start with the fact that we all know that women with type 1 diabetes have poor pregnancy outcomes. And macrosomia, which was described at least 80 years ago, is still a significant burden in the live births that we have. And again, associated with developing obesity, diabetes, cardiovascular disease early on in adulthood. Needless to say, tight glycemic control is our absolute focus throughout antenatal care in these patients. Hyperglycemia and pregnancy, again associated with a myriad of fetal and maternal complications. Just to name a few, I have enlisted them here. The standard glycemic targets as described by the ADA and our very own DIPSI are much tighter than when you are non-pregnant. As you can see, tight glycemic control is important for improved outcomes. So again, DIPSI recommends a fasting blood sugar of less than 90 milligrams per DL and 2 hours postprandial or post-meal levels less than 120 milligrams per DL. So again, glucose monitoring is extremely important, and the gold standard is finger prick self-monitored blood glucose, but that comes with a lot of cumbersome aspects for not only the doctors but also some anguish for the patients themselves. So again, while CGM or continuous glucose monitoring is revolutionizing diabetes clinical practice, and this diagram you have seen throughout in the first two talks as well, that it's not only a single glucose reading, but the trend, the continuous picture of blood glucose or glycemia in the body with the alarms and the different features, everything is available at once. So why not use it beneficially in pregnancy? Now again, the CGM glycemic targets, and many are described here, but for the sake of simplicity, we go with time in target range, which is TIR, and then we talk about TAR, which is time above range, corresponding to hyperglycemia, and TBR, which is time below range or corresponding to hypoglycemia. And again, the range that we consider for pregnancy is 63 milligrams per DL to 140 milligrams per DL. And the international consensus on TIR, which we know that was led by Dr. Tade Battolino, but Dr. Banshi Sabu from India represented India in this entire endeavor and has given several targets for different groups. And again, for type 1 pregnancy, type 1 diabetes and pregnancy, we know that we should follow from the evidence-based trials, we should follow a TIR above 70%, TAR less than 25%, TBR overall less than 4%, but severe TBR less than 1%. But however, the population of GDM and type 2 diabetes in pregnancy, we know that more is better, but how much or the exact targets are not yet defined purely because of the lack of evidence. Again, for type 1 diabetes and pregnancy, we know that every 5% matters, or 5% increase in TIR corresponds to nearly 1 hour a day, and that is associated with lower risk of LGA or large for gestational age, less risk of neonatal hypoglycemia, and lower NICU admissions. But for type 2 diabetes and for gestational diabetes, we really don't know what exactly we are aiming for, but the idea is to improve on the glycemic variability and of course improve on the time in range itself without any TBR. So CGM in type 1 diabetes, and I'm going to go through the evidence that we have thus far. Well, with smaller studies, comparing blinded CGM reviewed every 4 to 6 weekly versus standard care, or the real-time CGM in appropriate weekly intervals versus standard care, either we saw a small difference or we saw no difference at all. So that was confusing, and that led to the landmark concept trial, which was reported by Dennis Faig et al. In Lancet in 2017. And this was an international randomized controlled trial across 7 countries and 2 arms, predominantly including pregnant women and those who are planning pregnancy. They were randomized to either real-time CGM plus SMBG versus SMBG and standard care. The primary outcome here was change in HbA1c at 24 and 34 weeks, and secondary outcomes were maternal, neonatal, and glycemic outcomes, including hypoglycemia. So if you see in terms of the ethnicity included in the trial, or the BMI and duration of diabetes, the groups are well balanced at baseline, but the age and use of insulin pump is much higher in or greater in those who are planning pregnancy. Again, the primary outcome at 24 weeks and 34 weeks, there's a slight advantage with using CGM in HbA1c reduction. However, what was actually very important was the time in range, which improved significantly, or that 1 hour edge that we have, 16.3 hours per day with CGM use as compared to 14.6 hours per day with in the control group. And that is where the difference lies. And thus, there were no obvious differences in the maternal outcomes, but decreased LGA, decreased neonatal hypoglycemia, decreased NICU, and of course, decreased NICU admissions. So basically, concept trial was the one that defined the targets for type 1 diabetes and pregnancy. Now the next question which was asked was, which metric is really important? What should we really focus on? So this was an observational cohort study of 186 pregnant women with type 1 diabetes that were randomized to either receive CGM or intermittently viewed CGM, the Freestyle Libre. So Dexcom versus Freestyle Libre. And here, these women were managed 2 to 4 weekly and advised to do SMBG at least twice per day. HbA1c was also measured regularly throughout, and the primary outcome was LGA, or the neonatal composite outcome, including macrosomia, shoulder dystocia, neonatal hypoglycemia, and admission to NICU. Now, in the first trimester, it appears that HbA1c was clearly importantly associated with LGA. And why LGA? Because it's one of the commonest outcomes that we are faced with, and that correlated very well with HbA1c. Well, going through the second and third trimester, it appears that even the mean glucose is extremely important in its association with LGA. So thus, the strongest predictor of LGA was HbA1c in the first trimester, but in the second and third, it was mean sensor glucose. And this is important, and I'm telling you this because this can help us strategize our screening strategies well. Now again, the CGM metrics and LGA when viewed across the gestational months, and this is the combined data of the concept trial that I talked about and a Swedish study, and it included 386 women with type 1 diabetes, where they analyzed CGM glucose metrics and the 24-hour profiles across each gestational week. So basically, they are drilling down into the data, and you can see that the mean glucose, or the percentage time in range, and you can see the separation really beautifully at as early as 10 weeks itself. The blue line represents those with no LGA, and the red is in those with LGA. So you can see that this is separating as early as 10 weeks, which means we should aim for tighter control in the earlier weeks itself. Thus, differences in glucose levels emerged as early as 10 weeks and was sustained throughout the pregnancy, as you can see. Achieving mean glucose of less than 126 milligrams per dl was associated with a normal-sized infant, and early intervention before 10 weeks aiming at greater than 55 to 60% and 70% thereafter in TIR can reduce the incidence of LGA. Thus, we need to look at the CGM data almost weekly, on a weekly basis. In fact, it also showed us that appropriate timing and accuracy of carb counting can also help us, especially for the postprandial peaks. Now coming to CGM and its role in type 2 diabetes and GDM, again, definitely more studies were required because glucomoms, where it compared MDI or insulin pump and used blinded CGM, and the primary outcome was LGA, was non-significant difference between the two groups. And the other systematic review reported in 2022 was also inconclusive. So with all this, there was a lot of confusion. And I'm just going through glucomoms to give you a sense of what they looked at. Glucomoms was a CGM study during diabetic pregnancy and a multi-center randomized controlled trial looking at type 1 diabetes women, type 2 diabetes women who were pregnant, and also GDM, and using either intermittent use of retrospective CGM between 16 to 30 weeks. And here the glycemic control was assessed by CGM use every 5 to 7 days, every 6 weeks in the CGM group, while SMBG was done regularly and HbA1c in both the groups. And we found that in diabetic pregnancy, use of intermittent retrospective CGM did not really reduce the risk of macrosomia. In fact, CGM provided detailed information concerning the glycemic fluctuations, but as a treatment strategy did not translate into any improved pregnancy outcomes. So with that, moving on to type 2 diabetes further on, this is again a very important study, the today's study, because that tracked type 1 diabetes. This tracked young women with youth onset type 2 diabetes for almost 15 years. And they looked at the pregnancy outcomes in these. So this report consists of 260 pregnancies reviewed in 141 women, and they found that there was 65% had obstetric and neonatal complications, while 1/4 of the population of this study had either a miscarriage or stillbirth, and 10% congenital anomalies with higher cardiac anomalies if the HbA1c was maintained above 8% as compared to less than that. So based on observations from this cohort, young women with pre-gestational diabetes, type 2 diabetes, had very high rates of maternal complications stemming from insignificant or significant socioeconomic disadvantages. And thus, we can actually improve on these complications if we could improve the conception rate, and also the preconception counseling can be further reinforced. This sort of corroborates with the data that I just showed you. This is a national diabetes audit in young people with type 2 diabetes from the UK, and almost 57 to 70% of all pregnancies are with early onset type 2 diabetes, and only 33 to 50% had GDM. And amongst those with early onset diabetes, 16% are youth onset, but the majority, 84%, are between the ages of 19 to 25 years where they have developed type 2 diabetes. So you see, this is a very important problem, and the serious outcomes for these women with type 2 diabetes are only increasing. And this is not just LGA, it's a whole lot of congenital anomalies that are increasing in rate. In fact, if you compare the type 1 diabetes in blue and type 2 diabetes in gray, and across the tertiles of HbA1c in the 3rd trimester, you can see that type 2 diabetes is far more concerning than type 1 diabetes in terms of perinatal death as well. So again, this review of 5,000 odd pregnancies with early onset type 2 diabetes found that late pregnancy HbA1c of more than 6.1% represented in orange is associated with increased preterm births, LGA, and neonatal care admissions, just underscoring the fact that we really need to improve outcomes with enhanced glucose monitoring capabilities. Thus, coming to this particular paper, which shared the feasibility and acceptability of intermittently scanned CGM for women with type 2 diabetes in pregnancy, found that overall, despite all the limitations, CGM is feasible and acceptable as well to women. However, in terms of outcomes or the metrics itself, when you compare early versus late pregnancy, you can see that in terms of time in range, there's not much improvement with CGM use. And if you review all 3 trimesters, again, there's no difference at all. So, are we kidding ourselves? Should we really use CGM in pregnancy? And again, this was again highlighting the same thing, that with CGM, in fact, the HbA1c less than 6.1% in late pregnancy was in fact a tad bit less than those who were only following SMBG. And there were no lower death rates of preterm birth, LGA, and NICU admission as seen in this particular audit. So again, there is a lot of controversy, and we had this paper where high-risk type 2 diabetes women were tracked. Well, the number is less. It's only 41 for 15 weeks. And they saw that with increased sensor use, there was improvement in the CGM metrics during pregnancy, but only later. And these were very well associated with LGA in early pregnancy as well as with neonatal hypoglycemia. So it's telling us that there is a correlation, but we need to use it much more. So culturally appropriate healthcare strategies are critical for successful use of CGM technology. 2024, we had this particular question asked. Can CGM identify specific glycemic patterns early in pregnancy that may be associated with a OGTT diagnosis later in 24 to 34 weeks gestation? Basically, it's asking if CGM can be used to even diagnose or predict who's going to get GDM. And the answer is yes. Participants with GDM were found to have higher mean glucose, greater glucose, less time in range, and greater time above range. All this correlated really well in those with GDM as compared to those without. So prior to OGTT, between 24 to 34 weeks gestation, pregnant individuals who develop GDM have higher CGM measured glucose levels and more hyperglycemia as compared to those who did not develop GDM. So this is an important takeaway, that we can use CGM even to diagnose or predict who's going to develop GDM later. CGM in pregnancy, and this is a very nice paper in 2024. This is actually a commentary, and this shared that now an important gap seems to have filled between understanding maternal glycemia across the gestational age. And it also tells us very clearly that CGM is well tolerated, and even pregnant individuals without GDM are willing to wear it to understand how their glucose levels are going to evolve. Now again, the last couple of shreds of evidence. These are 2 important posters that were presented, or oral presentations, at the recent ADA in June. CGM in early gestational diabetes. I showed you various scenarios to diagnose in early type 2 diabetes. Now we're coming to early gestational diabetes, and the steady sugar trial, which compared unblinded CGM use to SMBG plus blinded CGM in women with early gestational diabetes diagnosed between 8 to 26 weeks. And the primary outcome was differences in maternal glycemic control, and secondary outcomes were differences in obstetric and neonatal complications and intensification of diabetes therapy. So here 128 women were randomized in a 2:1 proportion to the intervention group and compared with the control group. The intervention group was the real-time CGM Dexcom G6, where adequate support was provided, and the control was SMBG and monthly blinded CGM. And in terms of maternal outcomes as well as fetal outcomes, both are better with the unblinded CGM use or the real-time Dexcom G6 use. And of course, the intensification of pharmacotherapy was also better in the intervention group, and these women were found to be more likely to achieve TIR of more than 70% because of the timely intervention used. Neonatal findings were also improved in the intervention group as compared to the control group. Moving on to the next one, where Dexcom CGM use and satisfaction was studied in a diverse GDM cohort. Women with GDM showed better engagement and satisfaction with the CGM use, and definitely highlighting again that we can use it well in pregnancy. The mean glucose, time above range, time in range, and time in tight range were all correlated with gestational age at birth as well as the birth weight centile, and less tightly controlled glucose metrics were associated with early births and higher birth weight centiles. So conclusion was that compared to SMBG and blinded CGM, real-time CGM is the way to go and is much better in terms of maternal and neonatal outcomes. The actual proof of the pudding. And this has been published just 2 days ago, and I'm sorry it got switched. This is by Dr. V.Mohan's group, and Dr. Anjana is a co-author as well. This has just been published. This meta-analysis of 35 studies where they compared CGM use versus SMBG and clearly found that there were significant improvements in maintaining the time in range and reducing variability, with a whole lot of advantages that I already talked about with CGM use as compared to SMBG. And they urge us all to manage GDM by providing continuous real-time glucose data, enabling timely treatment adjustments. So that's the underline coming from Dr. Mohan sir himself. And last question is whether during labor or delivery or C-section, where we are actually talking about titrating IV insulin, again we know that the proof is CGM and AID at the time of labor and delivery appear to be safe and effective, although my disclaimer is that these studies had very, very fewer women. So in short, Standards of Care ADA 2025 supports CGM use in type 1 diabetes and pregnancy undoubtedly, and in type 2 diabetes and pregnancy we do not have enough data, and that's why they tell us that use it with SMBG. And this entire decision of using CGM in type 2 diabetes and GDM is individualized based on treatment plan, circumstances, preferences, and needs. And just remember that every 5% improvement in TIR matters because it's associated with amazing outcomes in terms of maternal and fetal parameters. So welcome to Mumbai for these two important conferences, and I thank you again for this patient hearing.